So good evening, everybody. I'm Beth Rosemary. I'm the education co-chair and the vice president of the MAFP. In honor of this being the month with Valentine's Day, and it's also Heart Month, we thought cardiology topic would be appropriate. So we're excited to have Dr. Zachary Luebbering talking about cardiac CT and chest pain, a paradigm shift. So tonight's presentation is delivered live, and the presenter will be available for questions after their talk. I know it's tempting to turn your cameras off, but we really encourage you to leave your cameras on and give our presenters opportunity to see and get a feel for who's on the presentation. Also kind of helps to keep you honest, so you're not doing charts or answering emails during the talk. You can drop a question in the chat and I'll monitor that, and we'll bring them up at the end of the presentation. I'll try to look at it during the presentation too, if it seems like it flows well. You can also speak up and ask questions directly at the end of the talk. And Dr. Luebbering, I'm sure, will be glad to answer those. We're recording this and it'll be uploaded to the MAFP YouTube channel for future reference. CME is only available for those who are attending live. So complete your survey at the end of the session tonight. Bill sent a link that you can just click on, and it's really quick and easy to put your information in there. This is the second of 10 topics that we have planned for this year in this format. So we encourage you to take a look at the list and to keep joining us maybe get some of your colleagues to do the same. We have a lot of good ones coming up in the future. So without further ado, welcome, Dr. Luebbering.
Thank you very much. I really appreciate the opportunity to speak this evening. On the instructions, it asked me to say a few sentences about my background and specifically about this topic. So I finished my training about a year and a half ago, and in the last year or so, I concentrated on multimodality imaging as it pertained to cardiac structures, and most specifically with cardiac CT, in the thought that, well, I'd end up in this position at Capital Region Medical Center here in Jefferson City and start a program here, which we have it up and running now, actually, and we've sent about 15 patients through. We've got excellent diagnostic images, so we're very excited about that. The reason why we're very excited about that is what I'm going to cover over the next 50 minutes or so here. Coronary CT, this new imaging modality or newer imaging modality, and especially how it pertains to its use in chest pain. And then, well, there is happening now a paradigm shift. Let's see, let's make sure I share my screen. All right. Does everybody see some slides?
Perfect. Thank you.
Awesome. Great. All right, here we go. I don't have any financial disclosures. So the objectives will briefly assess cardiac CT and calcium scoring and how those are acquired, and why this is a newer modality and what's changed to make this sort of imaging possible. I'm going to talk about calcium scoring and the difference of information that you gain from calcium scoring with the information and data that you obtain from the coronary CT angiogram, and how that can be used for clinical decision making. Of course, with new technology, we need to make sure, at least I mentioned landmark trials that show that this modality works. And we'll review guidelines that came out a little over 2 years ago now, and how the ACC AHA think that this needs to be incorporated into our diagnosis and treatments of chest pain, and then some future uses and also other uses of cardiac CT, despite in addition to chest pain uses. All right, so like the title says, this is a paradigm shift. So this is a busy slide, but hang with me for a second. This is maybe the paradigm that we're using now. A patient comes into your clinic, they tell you that they have chest pain. So of course, history, a physical exam. You might get an EKG, some blood work, cardiac biomarkers. Maybe if you're in the ED, get some troponins, and a chest X-ray. And from there, if your suspicion is high enough, you would then pursue some other form of testing. Some that's in quotes non-invasive testing here. Let's see if I have a laser pointer. Yeah, non-invasive tests. So these are traditional exercise EKG, stress echo, perfusion scans, or stress MRIs. And then there's this delineation that we might then move to invasive diagnostic imaging. So that's our diagnostic catheterization. I think the big thing to point out here is that diagnostic angiography in invasive cath, 62% of those patients that are referred for diagnostic cath have normal coronary arteries, no intervention is made, and you say, well, we need to look somewhere else. And then 38% of those go on to have some sort of intervention, be it stents or even bypass surgery. The people that get stents, these are being done ad hoc, meaning the information is being acquired, and then 30 seconds later, we're making a decision that we need to intervene and how we're going to go about doing that. The paradigm shift then with adding CT angiography is you do your history, your physical, your EKG, your blood work, all of that. And then you go straight to a anatomic test, this cardiac CT. You can, where angiography is done without catheters. There's plaque anatomy can be evaluated, and then from that information, you can make decisions on intervention prior to your trip to the cath lab. These interventions can be carefully planned, or I haven't seen this very often, but maybe you go straight to bypass surgery, and the pristine coronaries, the people with very normal coronaries, are ruled out before we ever get to an invasive procedure. Okay, so the Europeans are a little ahead of us on this modality. The UK had recommended this as first line imaging modality since 2016, and then the European Society of Cardiology since 2019. So there's a lot of experts from Europe that are kind of leading with this imaging modality. And then in November of 2021, this came out, and this is why we're talking about this. This is the one thing that we should remember from maybe all of these slides, is that for intermediate risk patients with stable chest pain and no known previous coronary artery disease, this coronary CT angiography is effective diagnosis of coronary artery disease risk stratification in guiding treatment decisions. And that's a 1A recommendation. So this is a first line 1A recommendation from the AHA, ACC, American Society of Echo, Chest, SCCT, all of them, even nuclear, say this is 1A. And then also this can be used in an acute setting too. An acute MI is ruled out in the emergency department and they have chest pain. You can send them through the CT scanner urgently and discharge them home. That's a 1A recommendation. All right, so now I'm moving into why this is coming up now. What has changed that has changed his chest CT into a cardiac CT, why we can image the heart so much better now. So the limiting factor in all this is that the coronaries are moving during imaging. You get blurry images. Think an old iPhone while somebody's running across the screen, it gets blurry. Well, the same thing happens to chest CTs. So we use a technique called gating. Basically, you put leads on the patient's chest, and the CT turns on or marks images during certain phases of the cardiac cycle. And this leads us to have images that are less blurry, less motion artifact. And we've gotten good enough now that we can see these tiny coronary arteries that might be as small as 3 millimeters or something like that. This would require a lot of radiation. And so to reduce radiation, we can change when we're turning on and off the X-ray tube during the cycle itself, or modulate the dose. And this is all controlled by this ECG gating. this makes it important for patients to have slower heart rates or regular heart rates. So someone with rapid AFib or something like that wouldn't be a good candidate, but with beta blockades and regular rhythms, even with not particularly new scanners, we can get excellent image quality. Speaking of new scanners, let's say at the university they have this thing that you see spinning here on the left or on the right, this dual source scanner. They've added a completely additional X-ray tube instead of detector rows, where you're basically doubling the speed, and the gantries themselves that the CT equipment rides on in the CT scanners spin faster now. They're adding detector rows, so anyways, we can get good pictures. This is kind of illustrating how the patient moves through the CT scanner. They take the images at certain R-to-R intervals, so gated at certain portions of the cardiac cycle. Most specifically, you see the red line there, acquiring images that's in diastole. That's when the heart is most still. And then the patient then moves the width of the detector rows, and then it turns on the X-ray tubes again, and it does this about 5 times, and you can acquire the entire volumetric data set of the heart in one specific spot in the cardiac cycle. Okay, so that's the nuts and bolts of all of this, and so let's talk about some of the data that we get. So first, I'll talk about coronary calcium scoring. So what is a coronary calcium score? It is a calculation of kind of a volume times density of calcium that is found in the coronary arteries. This is expressed in something called an Agatston score. This basically multiplies the Hounsfield unit, the amount of attenuation of the X-ray beam, multiplied by the volume seen on the CT data set. This has been around for a long time, and it has very low radiation, so it's useful for a screening tool because it's very non-invasive. This is near chest X-ray levels of radiation and is rather safe. It uses thick slices. It's prospectively triggered. What that means is basically that you don't need a lot of radiation to acquire this data set. And it's a constant tube potential, so it's you get a consistent number from machine to machine. You don't need contrast for a calcium score. So again, lowering the invasiveness of the test and making it a good screening tool. This is what the images come out looking like. You get less blurring artifact from motion because again, it's a gated study, but 3 millimeter thick slices that's not crisp enough, and there's no contrast in the coronary arteries themselves that I'm pointing in here to able to determine stenosis. So what you're doing then is you highlight these calcifications. This is in kind of the proximal left anterior descending artery. You highlight those. The computer generates a score, and that can be reported to the organ provider and patient. So what is the meaning of these numbers and what do we do with them? So these are a couple of guidelines that I found, the Lipid Association and the Society of Cardiovascular CT. So when would you do these? Greater than 40 years of age is what the Lipid Society says. So that's when we kind of start looking for coronary artery disease, or at least risks of coronary artery disease in the future. And then intermediate risk patients. These aren't patients that you have no suspicion forming this disease in the future, and not that already, or that you're pretty sure they already have, and they have to be asymptomatic. It's screening. This isn't something you would use with a patient with chest pain. So what do you do with it then? If you get a calcium score of 0, this might downgrade the patient's cardiovascular risk. You previously may have relied on perhaps like an ASCVD risk calculator or something like that, with those intermediate patients that might be hesitant to start a statin or want to be extra cautious and want to know if there's something more that they might need to be doing, in the intermediate range, you can get the score. If it's 0, maybe they don't need the statin. If it's greater than 100, high intensity statin you can recommend with more confidence and more data. And then both of these societies recommend 81 milligram enteric-coated aspirin. So this is illustrating kind of the risk factor modulation here. So with your very low risk patients, perhaps calcium scoring isn't all of that useful, because even if they do have some calciums, their statin still might not be recommended and they're at low risk. Your patients that are smokers or diabetic, for instance, is what is going to fall into this higher category here. You're not going to move the needle enough to say, never mind, no high intensity statin, no statin for you, because you're at low risk now. But your intermediate risk patients, this can really reclassify people and give you more confidence that you're finding the right people that you can benefit, or ruling out people that might not get benefit because they're at such low risk. So that's calcium scoring and its benefits there. I want to go through some images. This is a little technical, but it's kind of interesting to differentiate this sort of imaging modality from just normal CTs of the chest. So the first kind of way you might go about looking at these is something called MPR, multiplanar reformations. This, instead of just having kind of your axial views that a radiologist might go through, you can manipulate this 3D volumetric data set to get views that cardiologists and other cardiac imagers are used to looking at, specifically to the heart. So in this view in the top left, you see your typical 4-chamber where you can see the right ventricle, the left ventricle, the left atrium, and the right atrium in a way that an echo would image this heart, and is MRI, and even like nuclear images. These are all kind of normal views. 2-chamber view showing the aortic valve and the aorta coming out, and then a short axis view showing the ventricle kind of sliced and being able to see its wall thickness. And in this particular patient, you can appreciate a lead, a pacemaker lead in their right atrium, and then also in their right ventricle. These, again, are gated studies, so played in a cine format, going through the R-to-R interval. This makes the illusion of motion, and so you can even calculate ejection fraction with really good certainty. You can see the mitral valve in this picture opening and closing, and really get an excellent look at cardiac structures, and even in a dynamic way. This is the left atrial appendage. You can look for clots and things of that nature. This one, maximal intensity projections. This is more a view that looks more like a typical angiography. So this is something that you might see in like a cath lab. You inject your dye, and what it does is it takes a thicker slice, but brings the maximum intensity voxel, there's a volumetric pixel, to your eye, and it makes it look like angiography. So you can see kind of in its entirety, this, or in a good portion of it anyways, the LAD moving down the anterior of the heart, a diagonal. This is more of a cross section, or a short axis view, the RCA coming this way and the circumflex coming the other way. One really neat thing that makes beautiful images is these 3D volumetric reconstructions. These are incredibly useful for looking at different anatomical structures respective of one another. Is the circumflex coming across in this area or another area? If they have a coronary anomaly, is it running in between the great arteries? And you can get a lot of use out of that. This patient, you can see internal mammary arteries still attached to the chest. Well, it's really fascinating, beautiful pictures. These are the pulmonary veins coming into the left atrium. And then you can see how this would be really useful too for like bypass grafts coming up higher off in the aorta and seeing where those are running to. The last imaging reformation that I want to talk about is these curved reformations. Since it's this 3D volumetric data set, it doesn't have to be displayed in kind of a flat plane. This image is acquired by running a center line through an artery, and you can get, by spinning around that artery at 360 degrees, you can see the artery while keeping it all in the same plane all the way around. And really, this is a really, really nice way of evaluating tortuous vessels for stenosis. This is some calcium here on the proximal LAD. And you can see that despite there being a big chunk of calcium, there's still a lumen that goes around it, even though in some views it looks a little tight there. Okay, so the pictures are really neat looking. Let's see if we can gain good, useful clinical information and if we can improve patient outcomes with it. So landmark trials, April 2015 in the New England Medical Journal, Journal of Medicine, the PROMISE trial was published. This took 10,000 patients with chest pain and randomized them to either CTA versus functional testing. So what is functional testing? Functional testing is your traditional stress tests that you might think of. Stress echo, your perfusion imaging, PET or SPECT, or I guess you could do stress MRI. So what they were looking for is if CT patients' outcomes different from stress testing, and basically they didn't. CT group and the functional testing group with the primary endpoint of death, non-fatal MI, hospitalization for unstable angina, or procedural complications had no significant difference in between the groups, meaning these two imaging modalities had the same outcomes, but it did show a significant difference in the number of invasive catheterizations that didn't show any blockages. So basically, a significant number of patients went to the cath lab and did not have intervention or were found to have normal coronaries because they were ruled out already with the CT scan. I think this is maybe even a more significant finding. This is comparing event rates in patients, and they're categorized into normal and then all the way up to severely abnormal. So let's look at the graph on the right versus the functional testing with stress testing. If you were told that you had a normal stress test, you had a lower risk than if it was abnormal, or at least moderately to severely abnormal, but this line creeps up and sticks with the mildly abnormal line. Now, the anatomical testing event rates, if you had a normal test, that line stayed less than 1% out to almost 3 years. And the differentiation in between mildly abnormal, moderately abnormal, and severely abnormal were significant. And what that tells us is that if your test is normal in a cardiac CT, this is an incredibly reassuring thing. It has a really good negative predictive value, and you can, with great confidence, reassure your patients that your risk of future cardiac events is low. So if you have a negative CT, no further testing is necessary from the PROMISE trial here. The event rates at 2 years, no difference between stress testing and CT. And the prevalence of non-obstructive coronary artery disease, so people going to the cath lab, I guess we could call it unnecessarily, were 52% in the functional testing versus 27% in the CT. So basically 52%, not necessarily false positive, but didn't need that further invasive testing, or didn't benefit from it, perhaps. Again, negative predictive value from your CT. So, okay, that is PROMISE trial. Moving on to our next landmark trial. This one's called SCOT-HEART. And more specifically, the SCOT-HEART data that included their 5-year outcomes data. In this one, a little bit different. They randomized patients with chest pain to standard of care plus the CTA. So if they wanted to get a stress test, they still could, versus standard of care alone. So they were just barred from using this CTA. Primary endpoints were the same: death from heart disease, non-fatal MIs. So this time, our incidence of event rates, our death or non-fatal MI event rates were significantly different, especially at 5 years outcomes. You see these lines separating. Patients with CTA group lived longer than patients that received standard of care alone. This is mostly driven by these non-fatal myocardial infarctions. So people had less heart attacks that went through the CTA group versus the standard of care alone. And that's really interesting, right? Because CTA is not a treatment. We're not talking about treatment alone. So some new information is being provided that's changing how we go about taking care of these patients. So in that same point, the CT patients had increased chance of having catheterizations in the short-term period, though. So in the first year, patients underwent invasive coronary angiography a statistically significant more amount of times, but that difference in angiography disappeared even at about 2 years. So the other group caught up. Even revascularization, higher incidence of revascularization in the CT group at first, with that percentage going away at the 5-year outcomes. So I've been talking about how sensitive this test is and its negative predictive value. So you might think, well, fine, more people are getting treated with invasive therapies, but revascularization rates go away even at 4 years. So I'm going to propose this evening that the difference might be coming from finding patients with subclinical disease that's not obstructive, disease that wouldn't have been picked up by standard stress testing, which only really picks up flow limiting lesions. This modality will pick up lesions that are not flow limiting. It can have an enormous amount of information, and then medical therapy can be initiated before symptomatic disease ever presents itself. And then that might be driving some of these difference in outcomes. So Scott-Hart primary endpoints, like I said, death from coronary heart disease or non-fatal MI, standard of care versus standard of care plus CTA has a significant difference. Largely driven by non-fatal MIs, as we can see on this line. And then this is what our second page of graph showed here in number form. Invasive coronary angiography at 5 years, no difference whatsoever. And revascularization at 5 years, no difference whatsoever. So if you get a CT, it doesn't mean you get more caths. In fact, in PROMISE, it showed that you had less. And if you get a CT, it doesn't mean that you get more stents. At 5 years, the same number of patients got stents. This modality in Scott-Hart showed a broad patient population benefit. So young and old had significant benefits in, showed those outcome benefits less than or older than 65. Males and females both showed benefits. Where maybe the benefit is less as you have very low risk patients. So again, maybe these patients aren't as appropriate to do if you think that they're very low risk for having obstructive coronary artery disease. But obviously a benefit in the greater than 15% 10-year cardiovascular risk. Non-anginal chest pain, not quite as beneficial as anginal chest pain. So again, I think that falls into the risk category. Here's a good point that you'll see made on slides later in the presentation as well. If we know that they have coronary artery disease, calcified plaques and things like that, this modality isn't as good because where it really shines is this high sensitivity. If they already have coronary artery disease, maybe not as much information can be gleaned from the test. Diabetics, yes and no, both get a significantly this outcome benefit. So there we go. In conclusion, we have CT was associated with significant reduction in cardiac death and MI at 5 years. CT was associated with an increased risk in revascularization in the short term. So maybe we're identifying some patients earlier, but at 5 years, there was no increase invasive intervention. We were able to identify high-risk patients earlier and up-titrate medical therapies earlier and maybe preventing some risk some events in the future. And then something that's interesting, and I'll talk more about this a little later in the presentation too, is that low attenuation plaque burden was the strongest predictor for MI compared with risk scores. So that's your ASCVD risk scores. Calcium scores, we talked about those. So that's calcified plaques and stenosis. And so the stenosis thing is maybe the most interesting part. Previously, you get a cath report, you look at it and say, oh, you had a 90% stenosis in one of your arteries. This is high risk. This is something we need to pay attention to. This person is going to have a heart attack. Well, with the CT trials coming out, that is not how the best way to predict future heart attacks. It's looking at the plaque characterizations themselves. And this has been shown multiple times now that this is a better predictor of future cardiac events than percent stenosis that we're able to see with traditional angiography.
Dr. Luebbering, we had a question in the chat about the Scott Hart before
Please.
you leave that. So
Yep.
it was, were patients in the Scott Hart trial the asymptomatic or with chest pain?
No. Both of these trials were symptomatic patients. In fact, that's an excellent question. So, and that's, I'm really glad you bring that up, because for your asymptomatic patients, if you want to use sort of this type of modality and have the sensitivity, that's where your calcium score comes into play. And that's where you can see some benefits long-term with that. The CTA, when you're thinking about it, think of it more like traditional cath. This is kind of replacing the idea of taking them to the cath lab. These are for patients that would benefit from intervention. So with the ischemia trial, asymptomatic patients mostly don't benefit from stents. So there's no reason to go look for stenosis. There's no reason to go look for this as of right now. Anytime I've given talks on this topic, that comes up in cardiologists especially, or in patients even more so, really want to say, well, am I going to have a heart attack in the future? And I just told you that the strongest predictor of that is plaque characterization. So I can't imagine that this modality isn't going to be used as a screening tool in the fast future, but I can't talk too much on that, because that is not data driven, and that's not something that presents itself in the guidelines. And then if you try to get insurance to pay for it, you're going to need symptoms, just like a stress testing with imaging or a heart catheterization or something like that. All righty. Does that answer your question? All right, I'll assume it did then. So guidelines then. We touched briefly on this already, but this is the intermediate risk patients with stable chest pain. So they come to the clinic, they say they have chest pain that you deem, based on its how the patient's describing it and their risk factors and their age and all of that, is an intermediate risk. CCTA is an effective modality for the diagnosis of coronary artery disease, for the risk stratification, and then to guide further therapies, either medical or invasive. This is a 1A recommendation. I mean, it's a strong data-driven recommendation. That is how we should do this. And then, according to Scott Hart, we're going to make our patients live longer if we use this. And again, this patient population that we're talking about, a symptomatic patient without known coronary artery disease, the sensitivity is nearly perfect. And so what can that do? That can make our first line modality be an excellent first test, because if we say that there is not, if this test shows that there is not coronary artery disease, there's not this disease process underlying in your imaging, then that kind of, we can be reassured confidently. And this is across the board. Stable angina, MIs, sensitivity close to 100%, men and women, 100%. Typical angina, atypical angina, unstable angina, all of these exquisite sensitivity, and then negative predictive values nearly all verging on 100%. So as a first line modality, this is fantastic, because if this test is negative, then the workup stops for the most part, right? So, or at least, the workup for obstructive coronary disease causing symptoms. In that same time, your workup stops, meaning you don't need to go to cath or stress testing usually if it's negative. But if you do find anything at all, even if it's not obstructive, then there's an opportunity then to guideline future therapy. So then that's when you can have the talk about how important smoking cessation is, how managing diabetes, diet, exercise, and then statin therapies, of course, which we all have patients that are hesitant to add a pill, especially some of them might be their first pill. With this information, knowing that this is underlying, can be shed some more light on that. They give the same 1A recommendations for a similar population, non-known coronary artery disease patients with intermediate risk that present acutely. So this is your ER patient that has been ruled out, meaning they're not having a heart attack. They have negative troponins is how that's defined. So negative troponins, but with chest pain, and they're intermediate risk. We can reassure them and have a very safe discharge from the ER. And I have some papers from the New England Journal to back that statement up. The CT angiography for safe discharge of patients with possible acute coronary syndromes. This was published a while ago in 2012. They randomized CT versus standard of care. So pretty common study modality that we've seen a few times here. And then the event rates: death, acute MI, revascularization. Event rates were very low, and there was no statistically significant difference. So that's good. We weren't missing anything huge in the ER or anything like that during the study. So event rates are the same. So then why is this study important? Well, one thing I want to point out before I move on to the next slide is that cardiologist office visits were greatly increased in the population where CT was used. So what this then means is that the patients that perhaps didn't end up having a death or a heart attack or revascularization were still sent to cardiologist office, and this is because of that sensitivity. You're seeing subclinical disease, and these patients were sent to have further risk reduction therapies, medical therapies, leading to these better outcomes that I keep mentioning. The outcomes during this index visit. Sorry, my 1-year-old is not feeling very good this evening, so she's a little fussy. She turned 1 today, by the way. So outcomes during...
Posey is awake.
Uh-oh, and she's
Posey
awake.
is awake.
Outcomes during the index visit. So these are ER patients. And so what happened to them? Discharge was significantly increased from the ER in the patients that got the CT strategy. So remember, the outcomes were the same, but they discharged almost twice as many patients, or more than twice as many patients from the ER. So economically, you can see how hospitals are interested in this sort of things, and well, patients are too. They spend less time in the hospital. This is driven by, obviously, patients with a negative test, negative predictive value. Patients went home safely. And then, despite patients staying less long in the hospital and being discharged earlier from the ED, the diagnosis of the coronary disease was 3 times that in the CT group than the traditional care. So I know I've repeated that point 3 or 4 times now, but I just think it's so fascinating and so important that this isn't a thing that cardiologists want to put more stents in. Is we're catching these patients earlier in having primary prevention. We're catching them before their first heart attack. And this is something that cardiologists and primary care, of course, have great interest in. Interesting thing that they put in the chest pain guidelines, this concept of a warranty period. And so speaking to the negative predictive value of the test, CT gets this warranty period for 2 years versus normal stress testing of 1 year. So what does that mean? It means that if a patient comes in with chest pain and they have this chest pain that doesn't really change, well, if they have a stress test for 1 year, you might think about repeating that stress test every year. But if they have this pain for and they get the CT, well, we're confident that nothing new has come up and wouldn't come up in that patient population. So no need to repeat testing for twice the amount of time. Okay, great. This modality is good with bypass grafts. Bypass grafts are a little more challenging to image using traditional angiography. The graft takeoffs are not in the traditional spots where the catheters are meant to be go in. So different catheters have to be used, and it takes much more contrast and radiation to the patient. And so if you want to know if a bypass graft is open, CCTA is excellent at this. The grafts are larger, making them easier to image with CT, and they're not as mobile. They're not sitting on top of the epicardium. They're attached higher up on the aorta. And so you get excellent images. Sensitivity and specificity to graft occlusion is nearly perfect for CCTA. And so that's another great use for this that I haven't talked about so far. To illustrate this, this is a patient that was following at the university with one of the surgeons, and he had was following this patient. And what we're looking at, this is the 4-chamber view of the heart. This is the right ventricle, right atrium, left ventricle, and the left atrium. And this large structure here that's kind of dark with a small higher Hounsfield units area in the middle, this is a bypass graft that's aneurysmal. It blew up. It's very large. And then all of this is clot. This is all a thrombus. And then this is the lumen that's being imaged using contrast. And so with an angiography, you stick a catheter in here and you're just going to see the lumen, obviously. You're just doing a luminogram. That's all that's going to be imaged on your angiography. But with CT, this is that volumetric reconstruction, adding dimension to our 2D images. I'm changing the window width and leveling, looking at the different attenuation from the thrombus to the actual contrast. And you see this giant aneurysmal bypass graft going to the RCA or the PDA here. But this is all plaque, or this is all thrombus, and then inside here, sure enough, there's still lumen that remains. And so this is at risk of rupture. And so basically what we did is we followed this patient for a couple of years. We imaged them serially, and then eventually this completely occluded, and then it was no longer risk of rupture. And this is a really unique way of doing this. This is less invasive. And I thought this illustrated that bypass imaging really, really nicely, and shows such an interesting view of all of this. I briefly mentioned this earlier about how this can be economically efficient as well. CT scans are widely available. So kind of the addition to the CT scanner is just the gating material, this ability to perform ECG tracings while you're on the CT scanner. So it's easy enough from a hardware standpoint to implement this sort of thing. So the cost isn't through the roof, especially compared with even old modalities like nuclear perfusion imaging. CCTA is cheaper, and it's cheaper than cardiac catheterization, which requires a lot of staff, and then patient has to be in the hospital longer. So there's a study that shows that the ED costs were reduced by 38% in that same study that I showed you earlier about the ED patients that were discharged. So there are limitations to this. It's not perfect, and we have some advancements to figure out to make this better and more broadly applicable. The spatial resolution is not as good as traditional angiography. Traditional angiography spatial resolution is excellent. This being a 3D kind of slice-based modality, this computed tomography, the resolution is good, maybe 0.3 or 0.4 millimeters, but we're looking at very small structures, so there is some limit to that. If the patient has a variable heart rate, gating is difficult. So our scanner in Jefferson City is only a single source scanner, and I think it has 180 detector row slice. That's okay, but it's not as fast as, say, the 300 and something detector row slice dual score standard at the university. So we limit heart rate, probably needs to be in the low 60s to get excellent images, and we probably cancel the test if we can't get them down into the 70s. If they have atrial fibrillation, they're not a good candidate for this. Or very frequent PVCs or something like that can ruin the interpretability of our test. So lower heart rates and regular heart rates, especially on our slower speed scanners, or if you have the fancy stuff at the university, they actually can do whole heart imaging. They get basically the entire structure in one beat, which is incredible. The patient actually moves pretty quickly through the CT scanner. and heart rate variability plays less of a role. So as that technology becomes more widely available, the test will become more applicable to a broader patient population. Seeing inside of stents is difficult. Stent is made of metal, and so there's a lot of attenuation to your X-ray beam, then scatter, and something called blooming. It makes the stents look larger than what they actually are. The same thing, it makes viewing of the coronaries more difficult. Same thing with extensive calcifications. If you have an older patient that is higher risk, and these are high-risk patients, smokers, diabetics in their 70s and 80s, they will have calcifications, and so those calcifications again will be bloomed. They will look larger in the on the images, and it'll be difficult to determine whether this image is or this lesion is either 60%, 70%, 80%, something that we might need to send them further either stress testing or cardiac cath to determine whether it's significant or not. It needs to be intervened upon. So that's why these are patients without known CAD, without known coronary artery disease, and maybe on the younger side are benefiting from this test more. The contraindications are similar to the contraindications to just your CT scan. So if you have an allergy to iodinated contrast or something like that, that needs to be taken into account. This breath hold and cooperation business is so important because this test really, it's a battle against motion artifact from start to finish. And so heart rate, and then say they breathe during the test or they're not able to lay very still, our image quality is going to be reduced throughout all of that. And so that rules, and that in of itself rules out your unstable patients. So that's why the studies that we talked about earlier were done on patients where acute MIs had already been ruled out before they were able to be enrolled in these trials. Renal impairment is the same as any CT, and this also follows with cardiac cath because it requires contrast as well. Beta blockades, if you have some contraindication to metoprolol or something like that, or you have a high heart rate that we're not able to control well. I already kind of talked about that, but that should make you rethink and see if a different modality may be preferable. And then AFib or high rates of ectopy. So where is CT going to go in the future? What things are we excited about coming up over the next years? I've talked a lot about the able to predict risk based on plaque characterization. And so this is some images of plaques and how they were characterized in some of these studies and how they were related to outcomes in the future. And so these low attenuation plaques, these lipid-rich plaques, where this is, cholesterol and atherosclerosis that's not calcified, were shown to be at high risk. Even without this is probably not significant stenosis through this artery, but this and this has positive remodeling on it too. This is a high-risk plaque. This positive remodeling, what that refers to is see how the plaque then goes outside where the artery normally would lie and then comes back in. This is a high-risk plaque. Napkin ring sign, calcifications in a circumferential pattern around the artery itself, and then spotty calcification. So you see that in all of these, you have these little spots of calcification. These plaques are high risk of rupture. These are the patients that have MIs that we've had a really tough time predicting in the past because we've been relying on percent stenosis and things like that and risk stratification scores. Well, now we can actually look inside these plaques and determine imaging CT characteristics that may help us better stratify patients and identify patients that might benefit from intervention prior to the heart attack. There's other imaging modalities that could do this, but they're more invasive, intra-arterial echo and things like that. This is really interesting. I'll try not to spend too much time on this, but this is what I've been harping on about percent stenosis versus plaque characterization. This top yellow line shows a low-risk patient group in the blue with no plaque, meaning the high-risk plaque is not present, and then significant stenosis defined as greater than 70%. These are low-risk patients. Low-risk plaques, and not significant stenosis, low risk patient. And then, of course, if you have a high risk plaque that is significantly stenosed, greater than 70% in the lumen, these patients don't do well. But these two lines are where it becomes interesting. The patients with high risk plaque that didn't have significant stenosis had more cardiac events than patients with significant stenosis in low risk plaques. So again, this really highlights that high stenosis is rates, percent stenosis is not the end all be all of risk stratification for patients. And that's what we've been relying on for a long time. And so as CT evolves, we'll be able to identify these patients sooner, I think. It's called CT-FFR. This is something that you send off to like a proprietary company that tries to imitate functional testing, basically imitating a stress test by our images, even though it's not a stress test, and it's very good. It's called CT-FFR, and this is a study showing that sensitivity and specificity of CT-FFR is better than even, like, say, your PET stress test, traditional SPECT, or CT alone. These imaging biomarkers is something else that it's going to be more involved in. This is beyond even plaque characterization, trying to detect whether there is inflammation in those lesions, leading to higher rate of events in the future. So this is kind of a bit of a summary. So which test do you pick for your patient with chest pain? Do we want to rule out disease? We're hoping for a negative, and then we can kind of put this to rest. Or are we worried whether this is ischemia driven, meaning is this significant or not? Do they need a stent? We're already treating them for kind of the risk management. Well, to rule out the disease completely, CCTA is far superior. This is our go-to. Patients with already known disease or super high risk, now ischemia driven management is where we want to go in that, and we'll do that with traditional stress testing, your echo and your SPECT. Availability of expertise, likelihood of obstructive CAD. Well, age is a really good predictor of that. So your older populations, your patients greater than 65 years, this is where traditional testing might shine, as opposed to your younger patient population. CT is good. I really like this next line. Prior test results. If your CT didn't turn out great, or we're still confused about where this patient belongs as far as risk, well, we can switch it up and do functional testing, and vice versa. If your functional testing has some attenuation on it, or you don't like the result, or something doesn't smell right about the whole thing, well, you might switch to CT and get more information. Again, the Scott Hart trial didn't limit the use of both, and that's where we saw the improved outcomes. Other uses of CT, and this I could talk about this for hours, so I'll try to be brief, but anomalous coronary artery CT is exquisite at looking at the aorta. This is the gold standard. This is better than traditional CT angiography, because there can be motion artifact in the aorta, so this works better. If you're worried about pulmonary emboli and stuff like that, there's ways to running this test where it can get both. And so there's extensive use of CT. In that same CT cardiac imaging is also used in like TAVR planning. Broadly, you have to have it to size your TAVR valve. CT is used in, you can look at left atrial appendage closure devices to see either planning and signing, or seeing if the procedure was successful. And then a lot of cardiac surgeons get routine CT images because the anatomy is defined so well. All right, very good. I think that is the end of my slides here, so I can open it up to any questions, concerns, comments, anything anybody wants to talk about here.
So we had a question in the chat about, let's see, I think you answered a couple of them as we were going, but regarding beta blockade, do you have an idea of what's the best agent and dosing? You gave us like the target heart rate, I think, but that was the question.
Yeah, so there's multiple thoughts and multiple regimens that I've seen. At Capital Region, I'll tell you what we've been doing in our brand new program is that our cardiologists are ordering it, and so we kind of have an idea of where we want to go. And so if we need an oral beta blocker, maybe we give metoprolol tartrate like 25 or something like that if they're naive, and give that the morning of. But when they come in, they don't come straight to the radiology suite. They come into our preoperative unit, and this is treated more like a procedure. In the preoperative unit, we measure heart rate, and then we will give IV metoprolol, like a 5 milligram doses. And basically, the studies show that it's almost impossible to really cause harm in this. You won't get a lot of hypotension. You won't get a lot of symptomatic bradycardia with this, and you get much better imaging results. And so that's how we do that. We give, if with significant spacing in between the doses, it's very, very safe. In multiple studies are shown that this doesn't need to be physician supervised or anything like this. Nursing protocols are very safe and then effective at getting better images.
Thank you.
Is this, does a cardiologist stand by and do this test like they do a cath, or is this done by technicians?
So no, the technicians, so the only thing that's really different about this is this gating thing. And so the technicians are trained on the gating. Otherwise, they're very experienced at doing contrasted CTs. We've been doing those for decades and decades. So that really doesn't require any expertise. And then I just described that we think it's very safe to do these IV metoprolol protocols. So direct physician supervision is not required. I think what I see in the future for our protocols specifically is that we'll have someone available. So what does that mean? Kind of the same thing we do our stress tests is there's a physician in the building somewhere, but not necessarily in the room.
Question in the chat about the cost, and then I wanted to add to that. This is like probably needing prior authorization, I would imagine. So how does that apply to emergency room use?
So I don't have a lot of, so we're not using it in our emergency room now, and the university did this very sparsely where I trained. So I can't say that the if this would get denied or something like that, but I seriously doubt it. There's plenty of evidence to show that this is something that actually is a cost saving measure, and people live longer if you do it. So, but I don't know that for sure. Now, in the outpatient setting, I've had excellent results with asking insurers to cover these, maybe even better than like our PET scanner or something like that. I think it's insurers are aware of these AHA-ACC guidelines. They're aware that this is a good primary prevention tool, and we've had good luck getting them covered. Yeah, it hasn't really been a problem.
So overall cost comparisons, do you know that?
Yeah, so can you guys still see my slides here? Let's see if I can scroll through them. This is just one data set here. So those are the numbers that were presented in 2011. If I don't have a source for this, but CCTA has become less expensive as it's become more broadly applied. So I think these numbers are probably even more preferable to CT. Nuke is just expensive. Having the isotopes, generators, and stuff like that available, it requires a whole team. And so that's just been expensive, despite it being a modality that's well established. And then cath is labor intensive and carries its own risk. So there we go. This paper quoted the ED costs were reduced by 38.2%.
Do you know how long it takes to do the test?
So it takes a little bit longer than maybe your normal CT angiogram because of setting up of the gating, but it's not like an MRI where the patient's in the tube for a long period of time, and with seconds, 10 seconds is how long it takes to acquire. But the patient arrives earlier with the idea that they need an IV for contrast, and then they need an IV for the IV metoprolol that we're getting. And then there's some teaching from our technicians to coach them on breath hold and things like that. But otherwise, the test itself, the time that the X-ray tube is on and they're on the scanner, it doesn't differ that much from a normal contrasted scan.
So there's another question in the chat. Is this available at most hospitals or just research institutions like MU?
So I think it's just rapidly growing. I don't think I'm alone in recent graduated fellows that really took a great interest in this and read these HACC guidelines while they were in fellowship and thought that this would be something that they could kind of pioneer. So the Capital Region, well, it's now MU, Jefferson City or something like that. But we did those. We established the CT program before we were integrated with MU, and we are not a large hospital by any imagination. And so these are becoming more available. I know there's radiology groups as well, that just like radiology imaging groups that have them available too. So this doesn't even have to be performed in an inpatient or a hospital setting at all. This could be done completely as an outpatient in a radiology outpatient setting. And then CT, the calcium scoring is rather simple to do and very low risk, no contrast, low radiation, and that's done kind of broadly. The interesting thing about that is that insurance doesn't cover it at all, actually, which is interesting, but most places charge like $120 cash to get that done. And most places don't require an appointment because it's very, very quick, and they don't require an order from a physician is my experience in that.
So what is like the number needed to screen for calcium scoring?
What do you mean number?
Like how many people do you have to screen in order for you to like save somebody's?
No, that's a tough question. I'm not sure I have a number needed to treat for you, but I do have a slide kind of talking about, this is kind of where the data is, and then basically it's risk stratification. So really, I think how to look at it would be you look at your number needed to treat for putting someone on Crestor or rosuvastatin or whatever it might be. But with the calcium scoring, that number is going to be improved because you're not treating the patient with a zero calcium score. You're not treating the lower risk patient. You're narrowing your patient population that you're concentrating with primary prevention. And so your number needed to treat for a statin therapy, which is really, I think, where kind of how I see this test should be used. You're lowering that number.
And there's one more thing in the chat. It says, sounds like it's good, yes, no, and anatomic tests, but clinical presentation and functional testing might still be necessary to guide intervention.
Posey is away.
Yeah. So absolutely. So let's see. This is anecdotal, but we've sent like 20 patients through our scanner. We've only sent one to the cath lab, and they got a stent in their proximal LAD. So absolutely, this test is excellent. It is good, but this is not going to put our nuclear imagers out of business, not in any way, shape, or form, because the information that we're acquiring from it is very different. Again, one of them is an anatomic test, right? So maybe it guides intervention, but then if there's a question whether there's ischemia or there's areas of ischemia, this is not as good. Say you have a lesion that you're confident is 99% stenosis, well, we can infer that, yes, there's going to be ischemia there. They're likely going to get a stent. But if the lesion is 50, 60, 70, 80%, the CT is not as good at that. We saw the images, and the spatial resolution isn't quite up to angiography type images. And so it's not unlikely that a patient will get a CT test. We see it, we were looking for a negative, so we could put this to rest, but turns out you do have calcification. We're doing medical therapy, but the pain that you're having might not quite be anginal. So we need further risk stratification to see if invasive therapy is necessary. Well, then that's where this ischemia-driven management, the traditional stress testing, would really benefit that patient, and that's commonly used. They have a CT that came back as positive. We send them through our nuclear scanner to determine if this is something that we need to treat for primary prevention, or we already have significant clinical disease that needs imaging, perhaps. One more thing I want to say about that, I had one slide that had the CT FFR. This is kind of crossing over to functional testing that we're going to see more of in our careers. This is going to be something that we're absolutely going to have numbers come back. The CT FFR showed that it was not significant. It's our functional version of this test, and it will become more widely available and powerful.
Okay, well, we're a couple minutes past 7:30, but that was excellent. Thank you so much. Really
You're very welcome.
appreciate it.
Yeah, no, thank you very much for having me. As an honor.
Thank you all very much. I did drop in the link the survey for to provide some feedback to Dr. Luebbering, and then also to us as MAFP staff and planners for what you thought of this